más utilizado, aprobado tanto para el puente hacia el trasplante e incluso una bomba más pequeña, centrífuga, la HFAT, que está aprobada solamente para el puente para trasplante. Los dispositivos han evolucionado, como mencioné, de desplazamiento, donde tenemos un diafragma que sube y baja de manera similar al corazón normal, y la sangre entra, llena la cámara y luego sale, como lo vemos aquí en este diagrama, a un dispositivo que es una bomba de flujo continuo. Y en muchos de los diagramas vemos la letra CF, que quiere decir flujo continuo por sus siglas en inglés, y esto es un dispositivo axial, un flujo en línea que utiliza el principio de Arquímedes de pasar la sangre a través del ápice del corazón hacia la aorta con este mecanismo tipo hélice continuo, y luego una bomba centrífuga que está dentro del HFA, que tiene una forma de cono y tiene un aspa que gira generando una fuerza centrífuga que atrae la sangre y luego la saca. Hemos tenido experiencia con todos estos dispositivos. Cuando vemos un paciente que nos llega para soporte mecánico, circulatorio o dispositivos de asistencia ventricular izquierda, hay 4 opciones posibles, 4 desenlaces. Primero, que van a necesitar soporte para pasar a trasplante. Para nosotros ha sido más y más
or if
difícil
they're not a
obtener
transplant candidate,
corazones
or
de
a
donantes.
questionable candidate at the time of admission, too sick, multi-organ failure, maybe what we call destination therapy or permanent support, or in a very, very small number of patients, less than 1 or 2%, we plan to recover the patients, or eventually they'll end up with withdrawal of care. And this slide shows, using our national registry, the relatively rapid and explosive increase in the number of patients implanted for destination therapy since 2009 with the approval of the HeartMate 2 device. There's roughly 1,000 put in. It's now close to 3,000 we're estimating. And we've seen a slight increase in the number of patients over 60 years of age. Roughly half of the patients who get a device for permanent therapy are over 60 years of age. And that's just to show that circle. What really stimulated this was when we looked at the results of the HeartMate 2 trial, and this is the HeartMate 2 shown here with blood leaving the apex and going to the aorta, and it showed that it was better than the pulsatile, and using a previous study we were able to show that it was better than optimal medical management. And so you can see 2 New England Journal trials, one in the early 2000s and then almost a decade later. The first one, the rematch trial, compared medical therapy to what is shown here, the old pulsatile flow devices, and there was a divergence in outcomes right about the 6-month mark. Then the second trial, which I mentioned, compared the pulsatile pump to the continuous flow pump shown in yellow. And so we went from the bluish line here up to here, and this is now what we see with modern surgical therapies with the continuous flow pumps. And the net result, when you compare devices to medical therapies, is this differential in outcome. Optimal medical therapy probably has improved a bit since the rematch trial, but still, this is what we would say to a patient with class 4 stage D heart failure who presents to our institution. These are the courses one would expect to follow depending on whether we use a device or continue with medical therapy. We've also seen some surgeons and cardiologists begin to explore the possibility that the devices now compare quite well to heart transplantation. It's an alternative to heart transplantation, and I'll show you a couple slides to show you why they are thinking in this fashion. This is the modern therapy results for heart transplantation out to 15 years in adults. And this is from our national registry also. And there's been a slight but real improvement in survival over these 40 plus years or 30 years of therapy. Now the changes have been quite small. This compares to a recent publication by Jim Kirkland that was presented at the American Association for Thoracic Surgery, and what he showed was that if you look at a patient presenting for destination therapy using a continuous flow LVAD who has no risk factors or low risk factors, and by that, no renal dysfunction, no prior cardiac surgery, they have a survival curve out to 2 years that is indistinguishable from somebody who's had a heart transplant. And you can identify in this study patients who are at higher risk. The thing that was little discussed in this manuscript is there was a very small number, not a small number, but a relatively small number of patients who were low risk. Most of the patients presenting for long-term therapy have comorbid conditions that increase their risk, and I'll show you that in a little bit. From San Diego, a very experienced device center, they have an experience in a selected group of patients that shows that age doesn't, in their hands, seem to impact outcome when you choose permanent therapy. And here's their outcome for patients over 70 in blue compared to under 70 in red, and at 2 years they're indistinguishable. They have placed assist devices in patients in their mid-80s to support them, and they have a cohort of now 4 or 5 patients who are in their 80s who are supported with mechanical circulatory support. Now, like many of the randomized trials you've heard about earlier this morning, when you begin to look at the real-world data, it's not as perfect as one sees here. And where we're starting to get more and more real-world data is from this registry that we have called INTERMACS. It's a governmental, FDA, CMS, voluntary registry, but it's less voluntary than it appears, because if you want to be reimbursed by our government, you have to be part of the registry. So most centers that are putting them in are part of the registry. But you can see now, and we have now a Euromax group that just came on board in the last 12 months, we're having quite a large number of patients enrolled, which will help really understand what happens in real life. And I'll show you that in the next few slides. This is from the Journal of American College of Cardiology. It's a little hard to see, but this algorithm goes through how you evaluate patients for transplantation or assist device. And what I want to highlight in the next few slides is this. Consider a patient for left ventricular assist device therapy if they have things like they're too old, they are obese, they have pulmonary hypertension, they have HIV, renal insufficiency, hepatic insufficiency, and so on. So select them for destination therapy. And what I will show you is that if you do that, you will identify patients that are at risk for doing less well or having more complications. So this is the data from INTERMACS, which actually looks quite good and is very similar to selected centers, or centers that show their smaller series. The outcomes are actually quite outstanding. But you can start to see that there's a difference in outcome depending on the patient selection. Those folks we identify for permanent therapy do less well than those we select for bridge to transplantation, and that's because they have comorbid conditions that put them at risk for complications and death. This is a look at the INTERMACS registry in terms of age. Remember, I showed you the San Diego group that says 70 doesn't matter, when in fact in the national and international experience, as you are older than 65 to 70, you start to see a difference in survival early postoperatively and then throughout the course if compared to those less than 50 years of age. And most of us find now that if you are in your 70s, it is a tougher go with permanent support than for the younger age group. The Intermax group has identified levels of acuity, with one being the folks in cardiogenic shock. We've now learned that this subgroup of patients in critical cardiogenic shock has approximately a 20 to 25% early mortality. Most centers, including ours, are trying to stabilize the patient and get him through the cardiogenic shock phase with short-term devices like the Impella you saw earlier before going towards permanent therapy because of the increased perioperative mortality. Here's combining those two factors, age and the level of acuity on presentation. So if you're over 65, the sicker you are, cardiogenic shock, multiple inotropes, intra-aortic balloon pump, level 1s and 2, age and level of acuity plays an important factor in identifying the perioperative risk, which is maybe as high as 40% in an older patient in shock at the time of presentation. And it's been my recommendation to our team that permanent therapy for somebody in their 80s in cardiogenic shock is not indicated. And now, as I mentioned in that algorithm, if you have renal dysfunction, head towards permanent therapy. Again, coming from the Intermax group with a fair number of patients, any degree of renal dysfunction significantly increases the risk over 2 years, and if you're heading towards dialysis or end up on dialysis, there is a prohibitive mortality. And so most of us would say that a dialysis dependent or somebody near dialysis should not be a candidate for long-term mechanical support. And for the last 10 to 20 years, we focused on survival because many of these patients died within the first few months to within the first year. And now as we've improved survival out to 2 and 3 and 4 years, it's become obvious that adverse events are something we're going to have to master to really make this a therapy that is cost-effective and adds value. So when a patient comes in, of course they're worried about survival, but now when we talk to them, we have to look at some of these other issues. And so the first, one of the things patients really fear is a stroke. And this is the Intermax data on freedom or time to first stroke. And you can see at about 12 months, we have a 10% chance of having, a patient has a 10% chance of having a stroke, and by 3 years, about 20%. So thromboembolic events, despite the anticoagulations with antiplatelet agents and Coumadin, still remain a problem with these continuous flow devices. We thought since there would be no valves in these devices, just a continuous impeller, that we'd have less stroke issues, but that does not seem to be the case. The pump themselves are smaller, and the pockets that we make to put the pumps in are smaller, so we have reduced the number of pump pocket infections. But we haven't really been able to fully impact driveline infections. And what we've seen is in the younger, more active patients where there's trauma to the skin entry point, they start to have driveline infections. And once the driveline gets infected, it's almost impossible to cure that infection. So that is still a area where we're trying to figure out ways to reduce the infection at the driveline exit side. Bleeding. And the bleeding we're worried about are two mainly. It's gastrointestinal bleeding and it's intracranial bleeds. It's not clear at this point why we see these GI bleeds. One theory, there's a couple theories. One theory is that with non-pulsatile flow, the GI tract behaves like some patients with severe aortic stenosis, and they develop these atriovenous malformations that are predisposed to bleeding with the dual anticoagulation therapies. Another theory is that many of these patients develop an acquired von Willebrand factor deficiency, so they not only have a von Willebrand factor problem, they also have anticoagulation and then have these bleeding issues. Another theory for the intracerebral hemorrhages is that there's microembolization from the device occurring all the time, and that one of these subclinical infarcts then becomes a hemorrhagic infarct, and they have the bleed within their head. But bleeding, continue intracranial or GI is a problem, and data from our institution that's just will be published in JACC by Matt Bunty has shown that it has a significant impact on survival. If you have a bleed and if you have a second bleed, and we have another slide, that first bleed, folks are more likely to have a second bleed. A new problem that's originated in the last 2 years is pump thrombosis. We really went for a period with these new pumps without significant pump thrombosis, and we have a manuscript under review at the New England Journal of Medicine showing what we believe is an increase in the rate of pump thrombosis. And what we're seeing is in the top slide, this is one bearing, a ruby bearing. It's a ruby crystal bearing, and right underneath, you can't see it, is another ruby bearing. This is what's called an inflow or outflow stator. It realigns the flow, sort of smooths it out. And then underneath here is the propeller blades, and there's a bearing under here. And this thrombin, fibrin and platelet thrombus forms at the bearing. We think it's related to heat formation, which denatures some of the proteins. And then once this starts, it's a process that's very hard to turn around. And this is a cumulative slide, which is a bit sobering when you look at this, that if you take the time to the first major event, this is a combination of infection, bleeding, stroke, device malfunction, or death. And you can see how, despite those very impressive survival curves I showed you early in the talk, there are still a large number of events that are occurring for patients on these devices that are diminishing their quality of life, resulting in readmissions, as I'll show you, and increasing the cost of care. And this is from one of the papers I put together and we published in JACC earlier this year, where it looks at the cumulative readmission rate for folks after the device. And given enough time, every patient on one of these devices comes back into the hospital. We had one patient that had 44 readmissions. And they're a mixture of device-related and non-LVAD-related devices, and it varies from neuropsych and psychosocial issues, the elderly patients who have multiple medical problems and have mild depression. You put the device in, they still have multiple medical problems and still have mild depression, and they come back in the hospital. We have infection, which are both device and non-device related infection. All these things have led to an incredible burden on our mechanical circulatory support staff as they're trying to take care of new admissions and readmissions after LVAD therapy. And finally, earlier this spring at the International Society of Heart and Lung Transplantation in Montreal, there was a series of papers starting to identify this increased risk of pump thrombosis by looking at the development of either elevated hemoglobins or elevated LDHs. And what we have found, and others have found, is that if you start to have signs of pump thrombosis, it's a predictor of decreased survival. And what we found in our experience, we've had a number of patients that have had to have pump exchanges, and those elderly patients with comorbidities often elect or are not candidates for a new pump, and they end up dying. So this appearance of pump thrombosis at an increasing rate over the past 2 years has become a significant concern for many of us in the mechanical support community. So in summary, what we know is that there's a small number, and for us a declining number of heart transplant donors. It appears that somewhere now between 60, in our experience, to 80% of patients who will end up getting a heart transplant will need an LVAD. The remainder of transplant candidates will end up on an LVAD, and while they have gotten smaller and better, and the survival is better, we still have some work to do in improving the complications that occur, primarily strokes, bleeding, and the pump thrombosis. So I appreciate your attention and be happy to answer any questions.
Nos queda un espacio para preguntas antes de ir a tomar café.
Por favor, el micrófono, si es tan gentil, si no, no le podemos traducir al doctor.
Okay. They need the microphone to translate.
Claro. Good point. Claramente una conferencia que pone en contexto el problema real de los sistemas circulares y expone los reacios que hemos sido nosotros en esta institución a la utilización de sistemas de asistencia ventricular. Pero un análisis que no hizo usted y que me parece interesante oír es la relación o el análisis real de costo-efectividad de estos aparatos. En un centro como el nuestro, en un país como el nuestro, la utilización de esta tecnología probablemente resulta, en nuestra opinión, en una utilización de recursos exagerada en una población mínima de pacientes, lo cual sustrae recursos de otros que probablemente necesitan más cirugías de mayor efectividad a largo plazo. ¿Ya? Y lo digo porque en una conferencia, en una reunión reciente, vimos un estudio de costo-efectividad en donde se analizaban las terapias cardiovasculares en general, encontrando que la terapia cardiovascular menos costo efectiva de todas las que usamos es el uso de lovastatina, es decir, no hay nada más malo por el precio. Y lo segundo, y claramente de mayor costo, y que se identificaba como un factor determinante digamos, en la quiebra del sector de salud a nivel de Estados Unidos y el mundo, son la utilización de sistemas de asistencia ventricular. ¿En dónde quedamos? ¿Debemos seguir usándolos? ¿Debemos pensar en usarlos solamente en pacientes menores de 60 años o 50 años, en los cuales las curvas de sobrevida y los resultados son mejores? ¿O debemos seguir pensando que pacientes de 80 o 85 años nos sentamos muy orgullosos de que vivan 12 meses más?
Great question. I'll tell you my opinion. I don't think they're very cost effective, and I've been an outspoken critic of that at our institution. Now, they reimburse very well from our payers. So it's hard to tell the administration that this isn't cost effective when, in their analysis, every left ventricular assist device from the private insurers is equivalent to 3 or 4 standard cardiac operations. So if you do one LVAD, you have to do 4 bypass procedures to make the profit you do from a left ventricular assist device. So it's very cost effective to the organization as long as private payers are paying. Now, you've probably heard a bit about Obamacare coming down our way, and we're hearing a lot more about it as recent. If the reimbursement starts to look like a Medicaid reimbursement, we're not going to be putting a lot of LVADs in 80-year-olds and 65-year-olds because it will not be cost-effective to the hospital. It really won't. So I think we're going to have a reckoning shortly in the United States about how to use these cost effectively. It's simply, we won't be able to do it like we have done. And we will have to be very conscious of the total outcome, the value gained over 2 or 3 years rather than pure survival. And that's not been a philosophy we've embraced or been part of our DNA in the United States. But I believe if, and who knows where it's going to go, but I believe we will be more cost effective. We will be putting fewer of these devices in elderly patients unless they are in pristine condition.
Costo comparativo de mantener un paciente después de conectar la asistencia ventricular con el de un trasplante en términos de rehospitalización, readmisiones, terapia, inmunosupresión, admisiones por infección o por rechazo. Esos dos costos son comparativos. ¿Hay alguno de los dos que sea excesivamente mayor que el otro en el periodo post-implante o post-trasplante?
That's a great question. I don't know that that's ever been compared. The question was, is there been a cost analysis between transplantation and mechanical circulatory support? I don't know the answer. I think if I'd have to think through it, I bet you they in the post procedure, I bet you they're fairly similar, because there's quite a bit of intervention that goes on, at least for the first 2 years in the transplant, patients with biopsies, scheduled biopsies, and so on. But I don't know that I've seen an analysis that has compared those two. That's an excellent question. What's that? Oh, you're welcome.
My question is about the total artificial heart. Do you use in your center these kind of devices, total artificial heart? What is the role in the future of these kind of devices?
The question is, do we? Oh, she's saying it. Okay. Thank you. We have the total artificial heart, and I've put about 20 total artificial hearts in. The data, the outcome for total artificial heart is much worse than left ventricular assist device. So the survival is reduced by at least to 50% at 1 year or even less. And we select the sickest patients with profound biventricular failure to put the total artificial heart in. That's the only reason we do that. There's some patients with restricted cardiomyopathies where we can't fit a left ventricular assist device in. We would use it. Amyloid patients, or patients with catastrophic complications after an acute myocardial infarction, such as somebody who has occluded a dominant right, has a big VSD with posterior wall rupture and wide open mitral regurgitation on ECMO. That person gets a total artificial heart, but you can see how sick they are, and you can understand why. The outcomes report, it's a much more demanding operation than putting an LVAD in. You have to do a cardiectomy, you have to fashion 2 atrium, you have to do all these connections. So most surgeons are disinclined to use it. And so until recently, you couldn't discharge the patient from the hospital because the console that drove the system was as big as this podium. So they were committed to the hospital for a year, 18 months, at $1 million cost to the institution. So there were a lot of disincentives to the use of it. They do have a portable driver that's much smaller. It's about the size of a carry-on luggage that'll allow us to discharge the patient if it gets approved by the FDA. But the hopes, and I didn't show you a picture of it, is that we can use that smaller assist device, the smallest one, the HVAD, and put it in the left ventricular apex, and use another similar device and put it in the right ventricular free wall, and then you have to regulate the flows because it's continuous flow, and now have a total artificial heart or biventricular support using 2 VADs instead of a total artificial heart. Now, that'll just increase the cost. The total artificial heart to us is $100,000. 2 HVADs would only be $250,000, and up we go with the price. But those are some of the ideas we have.
Yo me quedo pensando, ¿cuánto está costando en promedio a ustedes cuando hacen las cuentas el aparato de soporte ventricular en el primer mes en promedio para terapia de destino? ¿Y a cuánto se elevan los costos cuando ocurren las complicaciones comunes de infección y o trombosis? En dólares, ¿de cuánto dinero estamos hablando?
The cost for the LVADs that we have, the total artificial heart and the two devices, the cost to us is about $100,000 to $120,000. The cost for a hospitalization, an uncomplicated hospitalization, is around $225,000 to $250,000. A complicated hospitalization where you need dialysis, you're in the intensive care unit, is often upwards of $500,000. So it's very expensive. It depends on the complications. A stroke, an intracranial bleed is an expensive complication. You're back in the intensive care unit for many days. That's a $50,000 to $70,000 complication. A driveline infection is a $5,000 or $7,000 admission. It's very expensive.